4 years later, this lady returned to the office now at the age of 61 with worsening fatigue. And based on those symptoms, repeat imaging was done, which showed again growing right inguinal lymphadenopathy, again up to about 4 to 5 centimeters in size. And again, lab testing revealed some cytopenias. So in a similar position to where we were before, symptoms, cytopenias, and diffuse lymphadenopathy. As is usually the case in people with relapsed follicular lymphoma, I think it's always important to rule out transformation, and so a PET-CT was done in addition to CT imaging. And the SUV max of the lymph nodes was again in the 9 to 10 range. So we didn't feel that it was necessary to rebiopsy anything to prove that it was still follicular lymphoma, not transformed to diffuse large B-cell lymphoma. She was started on a combination of lenalidomide and rituximab, and after 3 months, her symptoms had improved significantly. Her hemoglobin had gone up a little bit, her platelets had gone up a little bit, and by 6 months, her imaging had normalized. In somebody with relapsed follicular lymphoma, we have a lot of similar considerations that we had in the frontline setting, including, in particular, observation. Just because somebody has lymphoma that's come back, it doesn't mean that they necessarily need treatment right away. In fact, I would guess that most people who are asymptomatic at the time of relapse don't require treatment just because the lymphomas come back, particularly if it's picked up on some sort of imaging test. Some of us are occasionally doing imaging for routine surveillance, and an asymptomatic lymph node that's gone from 1 to 2 centimeters is certainly nothing to be disturbed about. In this case, however, she was having some symptoms and was again developing cytopenias, and so I think it was reasonable to consider second-line therapy. Again, the goals go back to where the discussion goes back to what is the goal of treatment in this case. And her preference was to choose some treatment that was likely to result in some sort of durable remission without a real intensive kind of therapy. In general, we have a lot of the same treatment options as somebody with new diagnosis, so single-agent rituximab is there, probably a reasonable consideration in somebody like this, although, again, it may take a little bit longer to work and it may not work for as long. Rituximab plus chemotherapy is a reasonable option. The same chemotherapy regimens that would be used in the frontline setting, although we probably wouldn't use the exact same chemotherapy regimen over again. That said, there is some data that suggests that some people can receive bendamustine more than once, but my bias has been to avoid that in general. Bendamustine as a single agent is approved by the FDA for treatment of people with rituximab refractory follicular lymphoma, and the combination of bendamustine plus obinutuzumab is also approved for people with rituximab refractory follicular lymphoma. So those are the sort of standard approved options. The NCCN guidelines, however, also list lenalidomide plus rituximab as a reasonable option in the second-line setting, and we're likely to see in the near future presentation of data from phase 3 clinical trials that indeed show that it's a reasonable option. We already have similar data from phase 2 clinical trials showing the activity of lenalidomide plus rituximab both in the frontline and relapse setting, but based on phase 3 clinical trials, I wouldn't be surprised if we have that regimen approved by the FDA in the near future. One of the interesting factors we have to consider when we start lenalidomide rituximab is how long are we going to continue therapy in this case. In the frontline trials, as well as in a published relapse trial, lenalidomide and rituximab was generally continued for about 1 year. In ongoing phase 3 trials, there are elements of the regimen that are continued for a longer period of time. So there's some heterogeneity in the literature about how long to use these treatments and at what doses, for example. In general, in somebody like this, we would start with 20 milligrams of lenalidomide plus rituximab for 4 doses, and then once every 8 weeks for the next year. My bias in somebody with indolent follicular lymphoma is not to continue indefinite therapy, and once we've achieved our original goal, which was to really get into a complete response or close to it. I'm not keen on continuing indefinitely and going beyond 1 year in somebody that achieved a good response after 6 months. I'm not sure that there's a huge role for that, or in other words, I think that the toxicities of the treatment at some point start to outweigh the ongoing benefit. So if, as in this case, a complete response is achieved relatively early on, I'm not keen on continuing indefinitely.